At the start of this series of lectures on ethics, I mentioned that public health ethics differ from those used conventionally in clinical practice. And since then, I've told you about the ideas of utilitarianism and social justice. Let me remind you of the 4 principles that underpin medical ethics: autonomy, non-maleficence, beneficence, and justice. As we've touched on previously, autonomy, or the right of a patient to make their own decisions, is perhaps the most challenging principle for us in public health. The idea of autonomy emerged as a reaction to what in medicine has been termed paternalism, quite literally the idea of the doctor as a father figure, making decisions that they deemed were in the interest of their patient. Now, there are multiple reasons for the rejection of paternalism, but perhaps the most salient is the emergence of technology and the reduction in what we term information asymmetry between the doctor and patient. Under early paternalism, a patient would know substantially less, if not nothing, about medicine compared to their doctor. But nowadays, with the internet and the likes of WebMD and Wikipedia, patients have access to huge amounts of information, and so that information asymmetry is reducing. But the rejection of paternalism goes further. It speaks to the ambition of consumerism and represents how society has changed from one of deference to one of challenge. Many high-income countries are increasingly moving towards patient-centered care, where patients have increased choice, share decision-making responsibilities, and even play an active role in their own care. In public health, we don't have that individual relationship with a patient. Instead, the population is our patient, and so our relationship with that patient is different. If you think about informed consent, in public health we're immediately and inherently constrained with what consent might be. Would it perhaps be an opinion poll, a focus group, or even a citizen jury? A population-level intervention may require a certain coverage to be effective, and achieving that coverage may not be possible without coercion. Herd immunity and vaccination is an example of this. Society benefits from achieving 90% plus immunisation coverage. Yet, in a busy world and with social media platforms enabling the spread of misinformation and the like, there are strong utilitarian arguments for overriding individual autonomy and forcing parents to vaccinate their children. The idea that children should be barred from attending school or public places, as has indeed happened in the US, could result in adverse outcomes for the child. And remember, it's not the child who's making that decision. So whose wishes do we take into account, and when is it appropriate to make a decision for the greater good? The bottom line is that autonomy in public health is problematic. In the example I've just given, the principle of non-maleficence is even called into question. But now let's turn to the principle of justice. I've already spoken about how the ideas of medical ethics are limited, and this is particularly the case for justice. The 4 principles of medical ethics are based predominantly on healthcare and its transactions, and they're based on a statist world idea. Statism is the belief that the state should control economic and/or social policy. For healthcare, justice can be easily applied within boundaries of an organising authority, be that country, state, or region. But public health is inherently global, and so how do we evaluate justice across countries, states, and regions? How, for example, do we appropriately compare justice in Northern Europe to Sub-Saharan Africa? We do need a code of ethics that better guides those of us dealing in population health. Now, there's no consensus on this, but I'd suggest reading the proposed principles from the American Public Health Association. Their code can be found in the AJPH article that's linked after this video. They have 12 principles, and we shan't go into those right now, but Jeffrey Swain's paper from 2008 builds these into 4 areas: interdependence, community trust, fundamentality, and justice. Interdependence is about achieving community health in a way that respects individual rights, or recognizing that the health of some often depends on the health of others. Community trust is about developing and maintaining trust through communication, community participation and collaboration, transparency, maintaining confidentiality, cultural appropriateness, and obtaining the community's consent for interventions. Fundamentality is about focusing on the underlying and primary causes of disease, as well as the key requirements for healthy communities, including the physical and social environment. Justice is about ensuring that the conditions necessary for health are accessible to all, including the vulnerable and, of course, the disenfranchised. Swain's 4 areas are not completely different to the principles of medical ethics. They touch on autonomy, justice, and, of course, helping others. But crucially, they're better suited to those of us working in population health. So that's where we're up to on public health ethics today. Along with Swain's 4 areas, you've previously heard about the Nuffield Council on Bioethics, whose principles from 2010 we tend to relate in the UK. And while you won't ever have to recite these 4 areas or a certain number of principles, you'll certainly have to consider ethical issues throughout your future career.